welcome everyone to the 5th virtual ward round this year on general surgery. For those of you I haven't met, my name is Victor and I'm a junior doctor working at the Royal Melbourne Hospital. And in these virtual ward rounds, I'll endeavour to provide some practical insight into how theory learnt from medical textbooks can be used to solve real-world clinical problems. In this lecture, as in previous lectures, I'll endeavour to take you through 3 interesting general surgery cases intended to give you a sense of the types of presentations that you will encounter on a typical gen surg rotation, and also how they are managed. So, as you're no doubt aware, the virtual ward round series is brought to you by Teaching for Impact, a not-for-profit organisation with a mission to use education as a weapon to create meaningful social impact. This year, all of our medicine lectures are being run as fundraising events for the Asylum Seeker Resource Centre, the largest independent human rights organisation for people seeking asylum in Australia. We share ASRC's belief that all asylum seekers deserve protection, respect and a chance to rebuild their lives, and invite medical students from across the state and nation to join us in our campaign to make a meaningful contribution towards this worthy cause. For those of you interested in keeping abreast of all of our tutorials and lectures, please scan the QR code on the right. And as always, I want to keep these sessions relatively informal. And at certain points, I'll put some questions to the floor, and I'd love it if you could all contribute answers to the online chat, or better yet, unmute and share your thoughts with the group, as learning is always more fun and effective as a dialogue rather than as a monologue. So without further ado, we might get started. So the first patient that we're going to see on our lightning fast surgical ward round is Miss GH, a 24-year-old female who presented with a 5-day history of epigastric / right upper quadrant abdominal pain. She has no significant medical history and is on no regular medications. She's from home with her husband and child, is a non-smoker, social drinker, and denies using any recreational drugs. So you probe a little deeper. She developed sudden onset epigastric / right upper quadrant pain 5 days ago. There was no radiation to the back, and the pain was described as constant and worsening with postprandial spikes 15 to 20 minutes following a meal. It was associated with nausea but no vomits. She also describes pale stools, which were regular. She tells you that bowels were opened last opened yesterday. It's normal in consistency, no PR bleeding. It's a bit of dark brown urine, but no blood and no dysuria. She has no history of gallstones, no previous episode of same. And she initially saw the GP who prescribed pantoprazole for query gastritis with nil relief. And so she ended up in the emergency and ended up being admitted under gen surg. So firstly, I might put a question to the floor, just based on the history that we've gleaned so far. What are we thinking in terms of differentials? And feel free to unmute and share your thoughts, or just post in the group chat. Yeah, gallbladder, cholecystitis,
pancreatitis.
Yep, pancreatitis. Fantastic. So any organ that is atypical appendicitis. Yep. NASH. Yeah. So mainly we're thinking liver, gallbladder, perhaps a bit of pancreas, stomach / esophagus as well. So the GP prescribed pantoprazole for query gastritis. I want to ask probably too easy a question. What kind of medication is pantoprazole? Cool. So it's a PPI. Perhaps a less straightforward question is what are the main adverse effects of pantoprazole or PPIs as a class of medications?
Like nausea?
Yep. Low magnesium, fantastic. GI infections, fantastic. B12 deficiency. I think Joss has hit the nail on the head with those three. I guess the only reason for asking is that this isn't generally something that we really consider, but pantoprazole is probably one of the most commonly prescribed medications, particularly on the gen surge ward. Pretty much every second patient is on either an oral PPI or a or IV PPI, or even a PPI infusion. So just a quick word about PPI. So as the name suggests, the drug irreversibly binds and inhibits the H plus K plus ATPase, which is usually located on the luminal surface of parietal cells in the stomach. And as you guys probably remember from preclinical medicine, parietal cells are responsible for secreting two things. Can someone remind us all of the two chemicals that parietal cells are responsible for secreting? No, so gastrin is produced by G cells. Yeah, cool. Yeah, so gastric acid and intrinsic factor. And intrinsic factor, you probably remember is important for vitamin B12 absorption. Without intrinsic factor, vitamin B12 will find it difficult to get past the intestinal epithelium at the terminal ileum where it's reabsorbed. So cool. So parietal cells are usually responsible for gastric acid secretion and intrinsic factor. And the gastric acid secretion occurs through an ATPase called the H plus K plus ATPase, which is inhibited irreversibly by PPIs. And the end result is, of course, decreased gastric acid secretion. So general surgeons love putting patients on PPI, but it's important to bear in mind that long-term PPI use has been associated with several clinically significant safety concerns. And I think Josh mentioned actually the main ones that I wanted to draw your attention to. So I've listed them on the slide, but the first thing is that PPIs have been associated with an increased risk of Clostridium difficile infections, even in the absence of antibiotic use. It's also a bit of, yep, sorry. So it's also been associated with malabsorption of two electrolytes / vitamins / minerals. So the first is magnesium, and the second is vitamin B12. And sometimes this can cause clinically significant hypomagnesemia and clinically significant vitamin B12 deficiency. Can someone tell me why is hypomagnesemia bad? What does it cause? Yes, it can cause hypokalemia. I think that the more important electrolyte I think that goes with magnesium is calcium. So profound hypomagnesemia, they say less than 0.5, a magnesium level of less than 0.5 can cause PTH resistance, so peripheral PTH resistance. And even lower levels of magnesium can cause a decreased secretion of PTH from the parathyroid glands, and that can cause sometimes clinically significant hypocalcemia. And hypomagnesemia-induced hypocalcemia is famous for being refractory to calcium replacement. So if you don't replace magnesium, you're never going to get the calcium back up. So that's one thing, but magnesium, yeah, magnesium like potassium is important for neuromuscular excitability. So, hypomagnesemia can lead to things like tremors, convulsions, tetany at its extreme. It can also do funny things to the heart as well, so cause QT prolongation. So we usually worry about hypomagnesemia when we're planning to place patients on long-term PPI, which is arbitrarily defined as PPI for at least a year. So really, if you're going to place patients on long-term PPI, you should routinely obtain a baseline magnesium level and serially monitor their magnesium levels at least every 6 months. The other baseline, vitamin/mineral/electrolyte level that you should do before placing patients on long-term PPI is vitamin B12. Because it can cause clinically significant vitamin B12 deficiency in the long term as well. And can someone remind us, why is vitamin B12 deficiency so bad? There are two main things that vitamin B12 deficiency causes. Yep, megaloblastic anemia is one thing, and neuropathy. And at its extreme, it can cause a condition called subacute combined degeneration, or SCD. Where you get degeneration of the dorsal columns, the lateral corticospinal tracts, and the spinocerebellar tracts. So it can cause peripheral neuropathy. Cool. And the other, perhaps less recognized side effects of PPI, which have come out of, phase 4 studies. So post marketing surveillance is the risk of acute interstitial necrosis, acute interstitial nephritis in patients with long-term PPI, and drug-induced lupus as well, which usually occurs, days to week after initiating PPI treatment, and the typical presentation is a rash. And I'm wondering what you guys sorry, I'm just getting a message. Why is there an increased risk of CDI? I don't know is the answer, but there has been a statistically significant association between Clostridium difficile infection and long-term PPI use in particular, but also an association with other enteric infections as well, but particularly C. diff. I'm wondering what people know about drug-induced lupus. So there are actually, it's actually rare to get PPI-induced lupus. There are two medications in particular that are the most common culprits of drug-induced lupus. Do you guys know what two medications that is? Hydralazine is one. And the other is a medication called procainamide. So procainamide and hydralazine are probably the medications that have the greatest potential to cause drug-induced lupus. And drug-induced lupus, as opposed to normal lupus, which if you attended, I think, the general medicine ward round, we talked about at length. But drug-induced lupus has a different autoantibody profile compared to normal lupus. Do you guys know what autoantibodies we tend to find in drug-induced lupus? So it's probably one of the MCQ questions that you might get. It's antihistone antibodies is present in pretty much everyone with drug-induced lupus, over 95%, and especially in those taking the two main culprits, procainamide and hydralazine. And interestingly, double-stranded DNA antibodies are typically absent in drug-induced lupus. Anyway, going back to the case, so you examine, well, firstly, you have a look at, flick through her charts, you have a look at her OBS and find that, the OBS are mostly stable. Probably has a low-grade temp of 37.8. On general inspection, she has quite obvious skeletal icterus, but you palpate the abdomen and there's some mild tenderness in the epigastrium, but otherwise the abdomen is soft and non-distended. You also make an effort to elicit Murphy's sign and find that she's Murphy's sign positive. There is, however, no peritonism or guarding. Here are her bloods. So white cells are normal, but CRP is mildly elevated. globally deranged LFTs. And I think the most impressive one is the bilirubin, which is quite markedly elevated. Her lipase is normal. So just a reminder that in order to diagnose acute pancreatitis, which we'll talk about in more detail later in this talk, the serum lipase generally has to be elevated above 3 times the upper limit of normal. And in this case, it's smack bang in the middle of the reference range, perhaps at the lower end of normal. So acute pancreatitis is unlikely. So, you know, given all this information, what would be your provisional diagnosis? And if you saw this patient in ED and you were the admitting Gen Surg Reg, what would be your plan for this patient? Sure, cholangitis is a possibility. So I guess, you know, we're basing our provisional diagnosis on quite limited information so far. So cholecystitis, cholangitis, they're all likely. They're all possibilities. But I guess, you know, beyond thinking about, you know, what it could be, what are you going to do for this patient? You know, this patient's come through ED, you're the admitting Gen Surg Reg. What's your plan? Analgesia, cool. She probably doesn't need that much analgesia. She's only mildly tender, but yeah, important. Any other investigations that you would want to order?
Adon mentioned an ultrasound in the right upper quadrant.
Yep. So abdo ultrasound. And what are you looking for there, Adon?
I guess if there's any gallstones that you can see or any other signs of inflammation.
Yep, absolutely. An ultrasound abdomen is probably the best test for gallstones. Cool. Anything else? Or you're just gonna write up a slip for abdo ultrasound and await the results. ERCP, pulling the big guns. But yeah, ERCP is not a procedure that's performed. Madison, you are Gen Surg. You are the Gen Surg. Anyway, so ERCP is not performed at all hospitals. Royal Melbourne does it. Boston does it. Ballarat only has, I think, two consultants who are trained in doing ERCP. So certainly if you're in one of the small country hospitals, then ERCP is not something that can be done at your hospital. You have to transfer the patient out. But yeah, ERCP is good for diagnostic and therapeutic purposes if you're suspecting colorectal, and we'll go into this in a bit more detail. But I feel, yeah, Adon's suggestion is pretty reasonable. I think I would order an ultrasound as an initial investigation. And this is the ultrasound report. So reading through it, liver's normal, portal vein is patent, gallbladder is reasonably distended, contains layering sludge, mobile echogenic foci, poorly calcified small calculi, slight wall thickening, 3 millimeters with increased mural vascularity and some edema. The CBD is dilated, measuring 10.8 millimeters distally and tapering off at the pancreatic head. There's no signs of pancreatitis. Otherwise, it's NAD. So the conclusion is dilated CBD with cholecystitis and sludge and small calculi. Likely distal CBD calculi, although there is tapering to 6 milliliters towards the pancreatic head. Cool. Okay. So the wall thickening. So just to summarize this, I guess. So you've identified multiple small calculi in the gallbladder. So that confirms polyscystolithiasis, and we'll go through what these terms mean in the next slide. But polyscystolithiasis just means the presence of stones in the gallbladder. It itself isn't a disease. You know, a lot of people have stones in the gallbladder that don't cause any symptoms whatsoever. But it goes on to say that there's slight wall thickening with increased mural vascularity and some edema. So this actually radiologically confirms acute cholecystitis, and we can be more specific. It confirms acute calculus cholecystitis that's caused by the gallstones. The other finding, so we have cholecystolithiasis, we have acute calculus cholecystitis, so an inflamed gallbladder. We also have the common bile duct being dilated, and that's a telltale sign that there might be a stone obstructing the common bile duct, and hence confirming or indicating the presence of choledocholithiasis, which is the presence of stones in the common bile duct. Do you have enough information to work out what the next steps in management are? Are there any other investigations that you guys would like to order? Blood culture has not been done, but could certainly be sent. I mean, yeah, white cells are normal and CRP is only mildly elevated, but sure, you can, if you're concerned about biliary sepsis, certainly send off some blood cultures, ideally before starting antibiotics. Yeah, Civil, why do you suggest MRCP and CT? Maybe unmute yourself and talk through your reasoning.
I think just to confirm where the stones is and where the site, to confirm is this, where does it start?
Yeah. So abdo ultrasound detected some common bile duct dilatation. It actually didn't definitively see any stones in the common bile duct. The common bile duct dilatation is very likely to suggest a calculus in the common bile duct, but it didn't actually see that on abdo ultrasound. So I will do some kind of ductal imaging. And someone before suggested an ERCP. As I said, ERCP is an invasive procedure, and we'll probably do something a little less intense to confirm choledocholithiasis as an initial step. And I think the best kind of imaging, if you can get it, is an MRCP. If the hospital's MRI machine is broken or has no availabilities for the next couple of days, you can do something called a CT IVC, which is a less good version of an MRCP. And the idea is to look at whether there's any obstruction in the biliary tree. So I would order an MRCP, and this is the MRCP report. So the MRCP is probably the most sensitive imaging modality for choledocholithiasis, and in contrast to the ultrasound of the abdomen, it's identified a 5mm calculus impacting the distal common bile duct. So you've confirmed choledocholithiasis. There is moderate dilatation of the intrahepatic and extrahepatic biliary tree. Liver is fine, etc. So it confirms cholecystolithiasis. It confirms, well, likely acute cholecystitis, and there's a 5mm stone impacting the distal common bile duct, confirming choledocholithiasis as well. Cool. So apart from analgesia, now that you have all this information, apart from analgesia, what are the management steps? Nil by mouth, cool. And IV fluid, cool. So what? So just to backtrack a bit, Madison, why do you want to keep this patient nil by mouth?
Just because I think this would be an indication for surgery.
Yes.
And also,
absolutely.
I guess it would make the pain worse if they're eating.
Yeah, that's both true and very valid comments. I think what kind of surgery were you thinking of doing on this patient?
Like a cholecystectomy?
Yeah, a lap chole. That's going to take out the gallbladder, but there's a massive stone in the common bile duct.
Yeah, so you'd want to get rid of that as well, which I think you can do with an ERCP.
Yes, absolutely. Yeah, so that is the best thing to do for stones in the common bile duct. So if you're at a hospital with no capacity for ERCPs, you want to be very quickly thinking about transferring the patient to a big hospital with that capacity. So yes, fasting is important. Fasting is also important actually for the scans that we've ordered on the patient. So an ultrasound abdomen looking at the gallbladder and an MRCP looking at the biliary tree, it gives you the best images if the patient is fasted. Because as you probably know, if the patient eats, that stimulates CCK secretion, which contracts the gallbladder, and so you're less able to see what's actually inside of the gallbladder. So yes, nil by mouth. IV fluids is reasonable as while the patient is nil by mouth. Anything else? Anyone want to start some antibiotics? Yes, no, maybe. Kevin met. Cool. Surgeon's favorite kinds of antibiotics, that and Tazocin. But yeah, reasonable to start IV antis on this patient. DVT prophylaxis, PPI, yep. Cool, and then fast theta for definitive management, and that's probably that's a very good approximation of what actually happened to this patient. So we'll talk more about the principles of management, managing acute calculus cholecystitis and cholecystolithiasis in a moment. But to summarize this patient's progress, she was commenced on IV Tazocin. And then, although she developed a bit of a rash and was switched to equivalent IV antis, IV clindamycin and IV metronidazole, and then she was transferred to an external hospital for an ERCP and consideration of a poly afterwards. So cool. With that kind of background, I think we might take this opportunity to quickly revise the anatomy of the gallbladder and the biliary system. I'm sure most of this is well known to everyone here, but as you all know, bile is produced by the hepatocytes in the liver, and then but the bile is then secreted into the intrahepatic bile ducts, and then the intrahepatic bile ducts become progressively larger and eventually form the right and left hepatic ducts. And just while we're talking about intrahepatic bile ducts and extrahepatic bile ducts, so it probably reminds me to ask the question, do you guys know what the difference between primary biliary cirrhosis and primary sclerosing cholangitis is? A very common med school question or a ward round question. Yeah, that's right. That's right. Yeah. So it relates to it relates to the bile ducts that's primarily affected. So primary biliary cirrhosis is usually intrahepatic bile ducts, and primary sclerosing cholangitis, as its name suggests, affects the bigger bile ducts. So extrahepatic, sometimes a bit of intrahepatic as well. But anyway, that's as an aside. So the right and left hepatic ducts then merge to form the common hepatic duct at the porta hepatis. And then after running a short course of about 4 centimeters, the common bile duct then joins with the cystic duct to form the common bile duct. And then the common bile duct then runs in the free edge of the lesser omentum behind the first part of the duodenum, and then burrows down between the pancreas and the second part of the duodenum, and then merges with the pancreatic duct to form the ampulla of Vater. And then empties into the major duodenal papilla on the posteromedial wall of the second part of the duodenum. And this major duodenal papilla is controlled by a sphincter called the sphincter of Oddi. So when digestion is not occurring and bile is not needed, that sphincter of Oddi is closed. So nothing can get into the small part of the duodenum from through the major duodenal papilla. And usually what happens is that the bile backs up in the common bile duct, goes through the cystic duct, and then is stored and concentrated in the gallbladder. And then when digestion starts to occur and bile is needed again, there are some enteroendocrine cells called eye cells in the intestine, which secretes cholecystokinin, so CCK, which does two things. So it relaxes the sphincter of body and it contracts the gallbladder, and that's essentially squeezes all this concentrated bile out into the second part of the duodenum for digestion purposes. Often gallstone disease, lots of long words and confusing terminology that all sound the same thing. I'm wondering whether someone can give me some definitions for these terms. So cholecystolithiasis, what does that mean? Just a short, sharp definition. Yep. Well, so not so much in the cystic duct. So cholecystolithiasis. So cyst refers to the gallbladder. So it's just the presence of stones in the gallbladder. Just a fancy way of saying stones in the gallbladder. Stones. There are 4 well-established risk factors for gallstone formation. And you'll remember the 4 Fs. So female, fat, fertile, and 40. And I think the thing to remember about cholecystolithiasis is that cholecystolithiasis, so the presence of stones in the gallbladder itself is not considered a disease unless it causes symptoms. So cholecystolithiasis without symptoms is just called cholecystolithiasis. Cholecystolithiasis with symptoms is called gallstone disease. And gallstone disease can be further divided into uncomplicated gallstone disease and complicated gallstone disease based on the presence or absence of 4 complications. And I've listed the 4 complications on the slide there. So acute cholecystitis, choledocholitis, gallstone pancreatitis, and something less common called Moritzi syndrome, which we'll talk about. But if there's one of these 4 complications, then we call it complicated gallstone disease. If none of these complications are present, then we call it an uncomplicated gallstone disease. Biliary colic. Can someone give me a short, sharp definition of biliary colic?
It's like intermittent right hypochondriac pain.
Yeah, that's right. So it's the term used to describe the pain that's classically associated with gallstone disease. So biliary colic, often described as this intense, dull discomfort located in the right upper quadrant, sometimes in the epigastrium. Sometimes patients may report it radiating to the back, particularly to the right shoulder blade. Often associated with things like diaphoresis, nausea, vomiting. And I think one thing that should have been emphasized in medical school is that despite the name, the pain in biliary colic is usually constant. It's not colicky. And typically the pain is worse after a fatty meal. And because, as you know, fatty meals lead to lots of CCK secretion, which causes gallbladder contraction. And biliary colic usually lasts about 30 minutes, and then it plateaus within an hour, and then it completely resolves after about 6 hours. So patients with biliary colic due to uncomplicated gallstone disease usually don't have things like fever, tachycardia, and the bloods like FBE, LFT, and lipase are usually normal. The fact that our patient had LFT derangement and had a low-grade fever probably means that this isn't just biliary colic. There's some complication of gallstone disease present here. And let's go through the 4 complications. So acute cholecystitis, can someone give me a short, sharp definition of that? Probably the most common complication of gallstones. Yeah, cool. Yeah, it's literally just code for inflammation of the gallbladder. And usually when we use it, we refer to a syndrome of 3 things. So right upper quadrant pain, fever, and elevated white cells. So leukocytosis. that's usually associated with gallbladder inflammation, as Joel said. On examination, patients with acute cholecystitis, as you guys probably already know, are usually Murphy sign positive, and certainly our patient was Murphy sign positive. And just a reminder that Murphy sign positive means, in respiratory arrest on right upper quadrant palpation due to the pain, as the gallbladder descends on your hand. Now, acute cholecystitis, there are two types of acute cholecystitis, divided based on whether it's caused by gallstones or not. So there's acute calculous cholecystitis, which is gallbladder inflammation caused by gallstones. And then there's acute acalculous cholecystitis, which is, gallbladder inflammation caused by other things. And those other things can be things like infection. So CMV infection typically can cause acute acalculous cholecystitis. Other things like hyperperfusion, typically seen in critically ill patients in ICU, can cause acute cholecystitis, and gallbladder stasis as well can cause acute acalculous cholecystitis. But acute calculous cholecystitis is by far more common. Cool, so that's acute cholecystitis. Polydocholithiasis, we probably already touched on. It's just a fancy way of saying presence of gallstones within the common bile duct specifically. Can someone give me a definition? So polydocholithiasis, so just like cholecystolithiasis, polydocholithiasis, so presence of stones in the common bile duct itself isn't a disease, although invariably it does cause disease. Almost invariably it does cause disease. But that term itself doesn't refer to the disease. And presence of gallstones in the common bile duct can cause inflammation to the common bile duct, which we call acute cholangitis, and that's one of the complications. So acute cholangitis, sometimes it's called ascending cholangitis. Same thing. So inflammation, usually secondary to infection of the biliary tree, due to biliary obstruction. So stasis is the basis of infection. So a biliary obstruction predisposes patients to infection of the biliary tree. And do people know what acute cholangitis usually presents with? There's a triad of clinical features called Charcot's triad. Someone remind us all what Charcot's triad consists of? Yep. So Joel's onto it. So jaundice, fever, and right upper quadrant pain. And sometimes when it gets really serious, there are two other things that can happen. So altered mental status and shock or hypertension. And that makes up Reynolds pentad. So Charcot's triad, Reynolds pentad are clinical features of acute cholangitis. So the third complication that can happen is gallstone pancreatitis, and this is usually due to passage of gallstones through the biliary tract, and then it obstructs at the ampulla vata. So it causes bile to reflux back into the pancreatic duct. That causes inflammation in the pancreas, causing what we call gallstone pancreatitis. And usually these patients, present with acute pancreatitis, so elevations in lipase, bilirubin, ALP transaminases are usually elevated. Are people familiar with Moritzi syndrome? Can someone give me a definition for what Moritzi syndrome is? Very rare complication, but can sometimes happen. Yeah, that's right. It's impaction of the gallstone in the cystic duct, and that causing extrinsic compression of the common bile duct or the common hepatic duct. But as I said, that's a fairly uncommon complication. So to recap, this patient has two of the complications. So this patient has complicated gallstone disease. One is acute calculous cholecystitis, and the other is polydocholithiasis as well. And just to reiterate, so the diagnosis of acute cholecystitis should be suspected in any patient presenting with right upper quadrant / epigastric pain, fever, and also elevated white cell or CRP. And if you examine the patient and the patient is Murphy sign positive, then that clinches, that supports the diagnosis. Now, the next step is usually, as we alluded to earlier, to order an abdo ultrasound. And on abdo ultrasound, you typically see two things in acute cholecystitis. So one is gallbladder wall thickening, or edema, so peripolycystic sort of edema. And the second thing is what we call the sonographic Murphy sign, which is similar to the Murphy sign elicited on routine physical examination, but except it's a positive response during palpation with an ultrasound probe when they're actually performing the ultrasound abdomen. And that's more specific and sensitive to your garden variety Murphy sign. But so if you see any of those two features on an abdo ultrasound, then you can diagnose acute cholecystitis. But sometimes the abdo ultrasound is equivocal, in which case you proceed to what we call a HIDA scan. And a HIDA scan is where HIDA is some molecule. It's labeled using a radioactive compound, and it's injected intravenously. And HIDA is then taken up selectively by hepatocytes and excreted into the bile. So if the cystic duct is patent, the tracer will enter the gallbladder, and you should be able to see the gallbladder without need for concentration, usually within an hour. But if you wait and the gallbladder isn't visualized within an hour, then you can take delayed images, which at 3 hours, at 4 hours, or you can do what we call morphine augmentation. And if you still don't see the gallbladder post morphine or delay images, then basically that's diagnostic of acute cholecystitis. It means that there's an obstruction at the level of the cystic duct. So in our patient, an ultrasound abdomen showed common bile duct dilatation, which suggests concurrent choledocholithiasis. And in patients in whom we're suspecting concurrent choledocholithiasis, we usually order, the best scan for that is an MRCP. And indeed, we did find concurrent choledocholithiasis in that patient. So how are we going to manage acute calculus cholecystitis? These patients need to be in hospital. If you don't treat these patients, sometimes the symptoms of cholecystitis can abate within a week, but complications are very common and have the potential to be very severe. So patients suspected with acute cholecystitis need definitive treatment. So there are three components to treating patients with acute calculus cholecystitis. So the first is, admit the patient under a gen surge unit for supportive care, and this, everything that everyone talked about: IV fluids while the patient is kept nearby mouth, correction of any electrolyte abnormalities, and pain control. And usually that's adequately controlled using simple things like NSAIDs and opioids. The second component of therapy is empiric antibiotic therapy, and it's well established that all patients with acute calculus cholecystitis should have empiric IV antibiotic therapy. What kind of antibiotics would you place a patient on? Usually you think about what pathogens you need to cover for, and just like you usually find gut bugs in the gallbladder. So the most common isolates are things like E. coli, Enterococcus, Klebsiella, Enterobacter, etc. Usually, the most commonly prescribed antibiotics is IV tazocin. Sometimes, you can use IV Kefenmet. Our patient was switched to IV clindamycin, which is just as effective, and IV metronidazole because she was thought allergic to penicillins and cephalosporins. But I think, IV antibiotics for all patients with acute calculus cholecystitis. And once they're started, antibiotics should be continued until either the gallbladder is removed or the cholecystitis has resolved clinically. The other component is a lap chole. We know that there are stones in the gallbladder, and the stones are the underlying cause of the presentation. So the definitive management will involve a laparoscopic cholecystectomy. This patient also has concurrent choledocholitis in addition to acute calculous cholecystitis. Usually in these patients, we transfer them to a unit that can do ERCP. So usually we do a pre-operative ERCP, remove the stone in the common bile duct, and then follow that patient, follow that up with a laparoscopic cholecystectomy in a couple of days' time. Cool. So bit of a recap. Can someone remind us of the 4 main side effects of long-term PPI use? So just in response to Sybil, I think the preference at the moment, guidelines, it is possible to do, a laparoscopic cholecystectomy and then an intraoperative cholangiogram to remove the stones. But I think that the preferred approach at the moment is a preoperative ERCP. I'm not actually across the data for that, but that's the most commonly used. Cool. So 4 main side effects of long-term PPI use. So we talked about increased risk of C. diff. We talked about hypomagnesemia, vitamin B12 deficiency. We talked about acute interstitial nephritis, and we talked about also the possibility of drug-induced lupus as well. 2 blood tests. You should therefore order routinely a vitamin B12 level and also a magnesium level prior to starting patients on long-term PPI. 2 clinical manifestations of vitamin B12 deficiency, so peripheral neuropathy and also megaloblastic anemia. 2 drugs most commonly implicated in drug-induced lupus. Do people remember? Yep, hydralazine, and the other one?
Procainamide.
Procainamide, fantastic, yep. What autoantibody is associated with drug-induced lupus?
You mentioned autohistone or something like that?
Yep, anti-histone antibodies, fantastic. 4 main complications of gallstone disease. So the first is acute cholecystitis, and then choledocholitis with or without acute cholangitis. And you can get rare things like gallstone pancreatitis if the stone is obstructing the ampulla of vata. And you can also get Maritzi syndrome, which is incredibly rare. And we won't go through Charcot's triad, Reynolds penta. I'm sure you guys are on top of that. And Maritzi syndrome, remember, is obstruction in the cystic duct causing extrinsic compression to the common bile duct. And the 3 components of managing acute calculous cholecystitis is firstly supportive care, IV fluids, replace electrolytes, etc., pain control. IV antibiotics for everyone. IV tazocin is the most commonly used antibiotic, but Kef and Met are equally good if you're not worried about Pseudomonas. And the 3rd component is a laparoscopic cholecystectomy. In patients with concurrent choledocholitis, you would need to do a pre-operative ERCP before laparoscopic cholecystectomy. Cool. 2nd case. Now I apologize, I'm fast running out of battery on my computer. So I'll let you guys read that. So I attempt to charge. Alrighty. So the second patient that we see on our general surgery ward round is Mr. IJ, a 74-year-old male presenting with acute onset severe central abdominal pain. Now, this patient looks more like a gen med patient than a gen surg patient. Quite a complicated past medical history. So history of metastatic melanoma, so melanoma actually metastasizing to the liver, previously treated with pembrolizumab. Now, does anyone know for brownie points what pembrolizumab is? What class of drug it is?
Monoclonal antibody?
Yeah. So Alex, do you know to what? Yeah, PD-1 receptor. So variously called an immune checkpoint inhibitor, or yeah, but it's a monoclonal antibody against PD-1. And what's the consequence of inhibiting PD-1? Meg? Yeah, inflammation. Yeah, so so PD-1 is found on T cells, and usually there's some other cell that expresses the ligand, so PD-L1 or PD-L2, which binds to PD-1 on T cells to inhibit T cell activation. So if you block PD-1, the PD-1 receptor on T cells, that actually prevents other cells from suppressing T cell activation. And so you get lots and lots of T cells being activated. And it's been shown that PD-1 monoclonal antibodies work quite well in a variety of cancer types, of which metastatic melanoma is one. Things like non-small cell lung cancer, often you'll see patients on pembrolizumab, et cetera, et cetera. But anyway, so this patient also has type 2 diabetes, a bit of peripheral vascular disease, hypertension, hypercholesterolemia, benign prostatic hyperplasia, GORD, and gout. The medications are listed. And again, for those who attended the Gen Med ward round, sorry for asking the same question, but why is this patient on Bactrim? Good. Whenever you see Bactrim and this Monday, Wednesday, Friday routine, it means it's for PJP prophylaxis. And why does this patient need PJP prophylaxis, Sybil?
The prednisolone?
Yeah. And what dose of prednisolone and at what duration would you need to consider PJP prophylaxis?
I remember it's 3 weeks, but I can't remember the dose.
Yeah, about that. So more than 20 milligrams for more than 2 to 4 weeks is probably enough immunosuppression to warrant some PJP prophylaxis. And this patient, I'll talk a bit more about the HOPC in a second, but this patient was initially started. So basically, developed metastatic melanoma, placed on pembrolizumab, had a few cycles of pembrolizumab, then developed immune-mediated hepatitis, which is a recognized side effect of pembrolizumab, and then was subsequently taken off pembrolizumab and placed on prednisolone 100 milligrams daily. With a slow wean. So this patient has been on prednisolone for the good part of the past month, and is now slowly tapering off. Currently on 12.5 milligrams. But that level of prednisolone would certainly warrant PJP prophylaxis. Some other random questions. Hydrochlorothiazide. Obviously, it's a thiazide diuretic. Do people know the side effects of thiazide diuretics? Another common ward round question. Probably less so in Gen Surg, more so in Gen Med. Yeah, good. Yeah. I won't be surprised if there's an association between the HCT and the gout that the patient's on. But anyway, just an interesting observation. So yeah, and also like gout, it's really uncommon to see, you know, first presentation of gout in a patient this old. You know, if you know, usually, you know, first presentation of gout in old people, you want to think of another cause, and usually that other cause is medication. The other question that I had, Duodart. Are people familiar with his medication? What is Duodart? It's a combination of two, and yeah, cool. Who was that? Annie? No, not Annie. Let's go with Meg de Boer. There were two Megans that responded. Meg, tamsulosin dunasteride, or well, dutasteride. How do they work?
Well, I think maybe one of them relaxes the muscle neck of the bladder.
Correct. Tamsulosin is an alpha blocker. There are some alpha-1 adrenoceptors around the smooth muscle, around the neck of the bladder. And if you block that, you relax the neck of the bladder. Cool. And dutasteride?
I'm not sure about that one.
Yeah, so it's a 5-alpha reductase inhibitor, and 5-alpha reductase is an enzyme that usually converts testosterone to the more potent dihydrotestosterone. And I guess, you know, that's sort of implicated in the prostatic hypertrophy or hyperplasia process. And so stopping that, you know, helps with BPH. So it's the most commonly prescribed medication for BPH, and you'll see it a lot. Cool, okay. A bit more about patient's HOPC. Onset of severe pain in the central abdomen around midday today, constant, no radiation, associated with nausea and 2 times vomits, bowels open, normal consistency of color, no fevers, chills, shakes, no history of gallstones, no alcohol intake. This patient has BRAF wild-type metastatic melanoma, and as I said, was due for cycle 7 of pembrolizumab about a month ago, but then developed immune-mediated hepatitis. With pembrolizumab, you can, because you know, the effect of pembrolizumab is it activates T cells everywhere. So the most common side effect is you can get autoimmune inflammation everywhere. So in any organ, it can cause hepatitis, it can cause nephritis, it can cause myocarditis, pericarditis, vasculitis, rashes, it can cause colitis, you know, pneumonitis, etc., etc. So it was subsequently stopped. The pembrolizumab was subsequently stopped, and then the patient was commenced on prednisolone, initially at a very high dose, but with a weaning plan, and has been on prednisolone 25 milligrams daily for the past 2 weeks, and then was recently stepped down to 12.5 milligrams. These are the bloods. So quite an impressive white cell at 20, mainly driven by a neutrophilia. You know, slightly thrombocytopenic, but yeah, whatever. Moderately hypernatremic at 129, which is interesting. GGT of 58. It's suspicious of alcohol intake, although the patient denies it. Albumin is a bit low. Can someone explain that? Why might the albumin be low? Yep, Joel's on the money. So yeah, in any infection or inflammatory state, you would expect low albumin. Albumin is a negative acute phase reactant. So you're not really worried until it drops like really low. You would expect a bit of hypoalbuminemia. Also, that's nothing. Fibrinogen is a positive acute phase reactant, so you would expect it to be a bit elevated. What is impressive is this lipase. As I said, to diagnose pancreatitis, you need 3 times upper limit of normal. This is like 20 times the upper limit of normal. So the diagnosis is probably pancreatitis. The lactate's also a bit high, and the glucose is a bit up. Why might the glucose be up? This patient is not a type 2 diabetic. Oh, well, wait, is the patient? Oh, no, this patient's a type 2 diabetic. Yeah, prednisolone. Yeah, so it worsens things. Anyway, so pancreatitis, sodium. Can someone explain that sodium? Are you worried about that sodium? Whoa, cryptic, but yes, I love it, Madison. That can certainly be contributing, and you need to have think about potentially stopping the thiazide if you think that's causing it. Anyone else have any other thoughts while I talk about hyponatremia? Yeah, pancreatitis itself can be a cause of hyponatremia. SIADH, Wai Chung, why do you suspect SIADH here in a patient with pancreatitis? So it certainly is a cause of hyponatremia. Why would a patient with pancreatitis? So yeah, so all of those are good things to think about. And I think I'll just cut to the point. So can someone remind us what the reference range for sodium is? Yeah, 135 to 145, and so hyponatremia is defined as a sodium of less than 135, and then based on severity, we can also classify or divide hyponatremia into mild, moderate, and severe, and it's in increments of 5. So mild hyponatremia is 130 to 135, moderate is 125 to 130, severe is less than 125. And can someone, might be a bit of an obvious question, but why is hyponatremia dangerous? Why are we worried? So hyponatremia means that there's not that much sodium outside of cells, and so by osmosis, water will move into neurons, causing brain swelling, which can sometimes be fatal. And so we worry when the sodium is not right. So once you find out from, so I'll talk through my process for, so hyponatremia is probably something that you will quite commonly see on the ward, and I think it's important to know how to think through hyponatremia, identify the cause, and know how to treat it. So this will probably be a monologue for the next 5-10 minutes, but hopefully it makes sense, and stop me if it doesn't make sense. So once you find out from the UEC that a patient is hyponatremic, the first test that you send off, and really the only test that you need to send off, is 2 things. So paired serum urine osmolality, and secondly, paired serum urine sodium. And from these blood tests, you can pretty much determine the cause. And I guess, often these, blood tests, so paired serum urine osmolality and sodium, they take a while to come back. So in the meantime, there's actually a very quick way to calculate serum osmolality. And there's a simple formula that you can use, which is 2 times the sodium, the serum sodium, plus glucose plus urea. And you can get that all from the basic bloods that we did. So 2 times the serum sodium plus glucose plus urea. And that's only a very, very rough estimate of what the serum osmolality is. And you can do a back of the envelope kind of calculation while you await the formal paired serum urine osmolality. So I guess, based off the serum osmolality, you can divide hyponatremia up into hypertonic, isotonic, and hypertonic. Now, if a patient has hypertonic hyponatremia, this is what we call translocational hyponatremia. And the cause, there's just one thing that could be causing it, and that is high glucose. So if you think about it, high glucose outside of cells would cause water to move from inside to outside of cells, and then that dilutes the sodium outside of cells. So hyperglycemia on its own can cause hypertonic hyponatremia. And usually if you correct the glucose with some insulin, you correct the hyponatremia. So that's one. Now, if you calculate the serum osmolality and it's normal, so if it's within reference range between 275 and 295, then this is what we call isotonic hyponatremia, or otherwise called pseudo hyponatremia. And there are only two causes of that. One is high protein, and the other one is high lipid. Now, this is essentially a lab error, and this is not a type of hyponatremia that we worry about. And it's a result of how they calculate sodium concentration in the lab. So the lab measures sodium concentration by dividing the amount of sodium by the plasma volume. And the plasma volume includes not only plasma water, but also plasma lipid and protein as well. So if there's high lipid or high protein in the blood, the plasma volume will be artificially high. And so the measured sodium concentration will be artificially low. So it's not like there's not enough sodium in the blood, it's just a lab error, and we don't really worry about it. Obviously, high protein might be, concerning for other reasons. It might be something like multiple myeloma or something. But generally, the hyponatremia is not something that is physiologically relevant. But if you calculate the serum osmolality and you find that the patient is hypotonic, this is what we call true hyponatremia. And this is the kind of hyponatremia that we worry about. Once you've established that the patient has hypotonic hyponatremia, the next step is to go to the patient's bedside and work out the patient's fluid status. So is the patient hypovolemic, euvolemic, or hypervolemic? And as an intern, this is something that you'll be called upon to do all the time, doing a fluid review or fluid status assessment, right? So you look at things like the JVP, you listen to the lungs for crackles, you look for peripheral edema, et cetera, right? To work out whether the patient is dry or wet. Now, if the patient is hypervolemic based on your physical examination, then it means that the cause of the hyponatremia is one of three things, and it's the three failures. So heart failure, kidney failure, or liver failure. And it literally just means that there is too much fluid on board and it's diluting out all the sodium. So the fix for that, the treatment for that, is to offload all of the excess fluid in the body. And so, put the patient on a fluid restriction and then commence some diuretics to offload the fluid. Cool. So that's hypervolemic hyponatremia. If you do a fluid status assessment and you determine that the patient is dry, then the patient is losing sodium and water in such a way that more sodium is lost than water. And the sodium can be lost, renally, or it can be lost extrarenally, usually via the skin or the gut through nausea, vomiting, diarrhea, et cetera. And you distinguish that based off the urine sodium, which you would have, worked out by ordering a paired serum and urine osmolality plus sodium. And if the urine sodium, if there's a lot of urine in the renal tubule, then that's telltale sign that the sodium is being lost renally. And the main causes of that are things like thiazide diuretics, as someone mentioned before, and acute tubular necrosis, right? So the treatment for that is make sure that you want to help the kidneys. So start the patient on some IV fluids and cease all the nephrotoxics, obviously cease the diuretic as well. Now, if the urine sodium is less than 20, it means that the sodium is being lost extrarenally, so not through the kidneys, and usually it's skin or GIT. And so usually the treatment of that is just IV fluids. Just start the patient on some IV fluids, and the hyponatremia should correct. Now, the most interesting case is euvolemic hyponatremia. And often this is actually quite difficult to pick out, because I don't know about you guys or whether you guys have done fluid assessments in the past, but sometimes it's really hard to distinguish between euvolemia and hypervolemia. Like obviously, if the patient has peripheral edema, bilateral pitting edema up to the knees, like it's pretty obvious that they're fluid overloaded. But sometimes people can be mildly hypervolemic, but the signs are too subtle for you to pick up on clinical examination. Anyway, if the patient is truly euvolemic, then the next thing that you look at is the urine osmolality. And again, you'll get that from that one test that you ordered. Now, if the urine is dilute, so if the urine osmolality is less than 100, then there are two causes. So either the patient is drinking too much and causing H2O intoxication, or the patient is malnourished. So the patient doesn't have enough solute or salt in the body. If it's psychogenic polydipsia, then the fix for that is place the patient on some fluid restrictions. Malnutrition, you just send off a dietitian review for a dietitian review and replace electrolytes. But the most interesting one is when the urine isn't dilute. And there's only one main cause of this kind of euvolemic hyponatremia, and that is what Wei Chung was suggesting, SIADH. And SIADH is the opposite of diabetes insipidus. So SIADH is the posterior pituitary pushing out too much vasopressin, or ADH. And as you know, ADH travels to the collecting tubules, binds to V2 receptors on the basolateral surface of the collecting duct, and then causes acetylcholine 2 insertion on the luminal surface, drawing water back up. So causes water reabsorption, but not salt reabsorption. And so that dilutes everything out, and you end up with hyponatremia. And then the reason why this doesn't cause hypervolemia is that the heart secretes ANP, and it flushes all the excess water out. So you end up with a euvolemic state. So I've listed there some causes of SIADH, and I think it's worth noting some of the main causes of SIADH. So some cancers can cause SIADH. So you can get mainly small cell lung cancers secreting ADH ectopically, and that can cause an SIADH syndrome. Any insult to the brain or to the lungs can cause SIADH, and I don't know what the mechanism of that is. I just think about the whenever you get a CNS insult, the brain freaks out and just squirts out vasopressin. Pulmonary, so lung insults can do it as well. Again, I'm not sure of the mechanism, but particularly one type of pulmonary infection, Legionella. So any type of Legionella has a strong association with hyponatremia for some reason. So if you have a patient presenting with pneumonia plus hyponatremia, think Legionella. There are a variety of drugs that can cause SIADH as well, and the main ones I've listed here. So SSRIs, usually given as antidepressants, opioids, and NSAIDs can all cause SIADH. So if you suspect SIADH, the treatment is threefold. So firstly, you treat the cause. So obviously, if you have a small cell lung cancer that's ectopically secreting vasopressin, you need to cut it out. But also you need to fluid restrict the patient. And sometimes when things get really bad, we would consider a V2 receptor antagonist that blocks the action of ADH on the collecting duct. And these are things like So the IV version is called conivaptan. The oral version is called tolvaptan, which is sometimes used. Cool. Okay, monologue over. So hopefully that clears up some things about hyponatremia. So in this case, I think the most likely cause of the hyponatremia, and this will be confirmed by the serum osmolality. And as I said, we can do a back of the envelope calculation of the serum osmolality. And in this patient, we actually found that the serum osmolality was high, suggestive of hypertonic hyponatremia, which is a translocational hyponatremia caused by the hyperglycemia, which was in turn caused by the prednisolone, which is pretty interesting. It's interesting that so we gave this patient some insulin, the glucose came back down and the hyponatremia resolved, but then a couple of days into his admission, he developed hyponatremia again. And this time in the setting of hyperglycemia. So he developed some swelling in the legs, and we could hear some crackles bibasally. What we think is that so in pancreatitis we always worry about third spacing, so we aggressively replace patients' fluids. And what we think happened was by that time, when we first noticed this hypervolemic hyponatremia, the patient had 7 liters of IV fluid since his admission. So I think we were over hydrating this guy, and we placed him on a fluid restriction, and the hyponatremia came back down. So anyway, from the lipase, going back to the case, a diagnosis of pancreatitis is very likely. Again, I pose the question: if you were in ED admitting this patient as the Gen Surg registrar, what would your plan be, and what other investigations would you like to order? Or are you quite happy with the diagnosis of pancreatitis just based on the lipase?
Do you want a CT abdo?
Oh yeah, talk me through it. Why do you want a CT abdo?
Perhaps you can see the severity of the pancreatitis, and if there is third spacing or things like that. I'm not sure.
So what are you looking for? Like, what is radiologic evidence of pancreatitis? What are you looking for on CTAP? And I think you're completely right. We ordered a CTAP on this patient.
I know one thing is fat stranding.
Yep. Yeah. Actually, that's like the only thing that you look for. Okay. So yeah, fat stranding around the pancreas is telltale sign that the patient has acute pancreatitis. Cool. Any other investigations apart from the CTAP? So I think if you order the CTAP with that kind of lipase, you're almost invariably going to see fat stranding and a diagnosis of acute pancreatitis. Any other investigations that you might want to order? This is more leaning down towards, okay, we're pretty sure this is pancreatitis. What might have caused this pancreatitis? I'm trying to work out the cause. What other investigations would you order? Feel free to contribute in the chat as well. Any other blood tests, imaging modalities? Oh, sorry, I've been. Add on CM. Oh, that is juicy. Wai Chung, can you explain why you want a calcium? Oh, well, yeah, CMP, we've already ordered a CMP, but why is CMP important in pancreatitis? Yep, cool. What can calcium? So, I guess it's an unfair question. I'm asking you to read my mind, but the thing is hypercalcemia. So high calcium is a cause of pancreatitis, and secondly, pancreatitis, when it gets really bad, it can release all this lipase into the blood, and that results in a phenomenon called fatty saponification. And so fatty acids get released into the blood and binds to calcium and can cause a hypocalcemia. So hypocalcemia is a complication of pancreatitis. So which is why we're really interested in how calcium levels change in pancreatitis, because high calcium can cause pancreatitis, but then as a complication of pancreatitis, you can get low calcium as well. So cool. I would make sure that a CMP is ordered. MRCP, yeah. I would probably order an ultrasound of the abdomen first. But yeah, if you have concerns around choledocholithiasis, certainly MRCP. Cool. Lipid studies, I would certainly be interested in fasting triglycerides, because triglyceridemia, as you probably are aware, is a cause for pancreatitis. So, I mean, causes of pancreatitis, gallstone, we're investigating using an abdo ultrasound, plus or minus an MRCP if you're worried about that, choledocholithiasis. Alcohol is probably the second most common cause for pancreatitis, and I guess we'll elicit that on history. The patient denies drinking, but the GGT is elevated, which is a bit sus. So we've gone through hypercalcemia, we've gone through hypertriglyceridemia, which we're investigating using fasting triglycerides. Any other causes that we might want to investigate for? I think that's a pretty good start. The other thing which is a bit cryptic is, I'm not sure if anyone has heard of autoimmune pancreatitis. It's usually associated, well, there are two types of autoimmune pancreatitis, type 1 and type 2. Type 1 is usually associated with IgG4 related disease, whereas type 2 is usually associated with inflammatory bowel disease. Often, you know, if you exhaust your options, you do an abdo ultrasound, you know, and order all those bloods and they're negative, and you're scratching your heads as to what might be causing the pancreatitis, an IgG4 level could be informative for diagnosis of autoimmune pancreatitis. Anyway, as someone suggested, we did order a CTAP. Yeah, scorpion. Yeah, we'll talk about causes of pancreatitis in a second. But yeah, CTAP, this is a report, periopancreatic stranding around the body, core extending inferiorly to the level of the Antoinette process. So pretty much confirms our suspicion that this is acute pancreatitis. And we just, you know, went through the causes. You know, the most common cause is gallstones, second most common cause is alcohol, and there are others as well, weird and wonderful, that we can investigate. You know, because the most common cause is gallstones, ultrasound abdomen is a must for all patients with pancreatitis. And we find no stones and no evidence of acute cholecystitis. So unremarkable gallbladder, no biliary obstruction, cholelithiasis or cholecystitis. All right, so can someone offer a provisional diagnosis of what might have caused the acute pancreatitis? Let's go back to his history. Hypercalcemia, so that's the CMP, it's normal, calcium is normal. Thiazide is most certainly a sulfur drug. Oh, people are saying pred. PPI induced pancreatitis. Yep. So we should be thinking drugs in this case. We've exhausted a lot. Well, you know, supposing you believe the patient that he doesn't drink, and we didn't find any gallstones on the ultrasound abdomen, we need to really be branching out. We should order those additional blood tests, like a fasting triglyceride level and potentially an IgG4 level as well. Yeah, you would be suspicious due to the time course of steroid-induced pancreatitis, which is a very real thing. Cool. So diagnosing pancreatitis, just a quick word. So obviously you would suspect a diagnosis of acute pancreatitis in any patient with acute onset, persistent, severe epigastric pain with tenderness on palpation. And to diagnose pancreatitis, you need the presence of 2 of 3 criteria. So first, so the 3 criteria are clinical criteria, laboratory criteria, and radiological criteria. So the clinical criteria are, obviously symptoms that match pancreatitis, acute onset of persistent severe epigastric pain radiating to the back. Laboratory, so you need an elevation of serum lipase or amylase to at least 3 times the upper limit of normal. If it's not at least 3 times the upper limit of normal, pancreatitis is very unlikely. And the radiological criteria is you see characteristic findings on imaging, and most commonly it's a CT abdo-pelvis, and you see fat stranding as well. Cool. So our patient actually satisfies all 3 of these criteria. And so we can diagnose acute pancreatitis. But as I've alluded to, it's not enough just to diagnose pancreatitis. You need to work out what's causing it. And just a quick word about causes of pancreatitis. I know, there's this I get smashed mnemonic. I don't really like this mnemonic because it's way too long, and I can never remember what each of them stand for. And there are also some really irrelevant ones like scorpion sting that no one really thinks about. So I think on the right, I've sort of ordered them in terms of frequency. So gallstones and chronic alcohol use is probably are 2 of the most common causes of pancreatitis. Together, they account for 2/3 of cases. So gallstones is probably by far the most common. 40% of cases are caused by gallstones. And interestingly, small stones, so less than 5 millimeters in diameter, have been shown to be significantly more likely than larger stones to pass through the cystic duct and cause obstruction at the ampulla vata, resulting in gallstone pancreatitis. Alcohol is the 2nd most common cause, accounting for 25% of cases. Elevated triglycerides is an important cause. Usually, it's significantly elevated triglyceride levels, so above 11 has been shown to precipitate attacks of acute pancreatitis. Post ERCP, probably not that commonly seen. Therapeutic ERCP, where you actually remove some stones, has been associated with a higher risk of pancreatitis. There's also some rare genetic things that if you're really scratching your head, or if you have a patient presenting very early on or has a family history of pancreatitis, you can start doing genetic testing. Medications overall is really rare, accounts for less than 5% of cases of pancreatitis. Pancreatitis, so drug-induced pancreatitis has been divided now into 4 classes based off the how likely they are to cause, or what their potential is of causing pancreatitis. And class 1 being drugs with the greatest potential. And class 1 drugs include things like Gallstone, which if you attended the Gen Med talk, we talked a bit about Gallstone, sometimes used for a 2nd-line agent for PJP prophylaxis. Things like furosemide have a great potential to cause pancreatitis. Mesalamine, commonly used in ulcerative colitis. Metronidazole antibiotic use, valproate, an antiepileptic, amiodarone, azathioprine, and dexamethasone is a class 1 agent for causing, but prednisolone is a class 3 agent. So there's an association, but it's not as strong as IV dexamethasone. But in any case, this case was put down to this case of pancreatitis was actually put down to prednisolone. Even though I actually think Bactrim, Bactrim is a class 1 medication that has quite a strong potential to cause pancreatitis. I think the Bactrim is actually quite suspicious and actually has a higher proven greater potential to cause pancreatitis than prednisolone. Anyway, so this was put down to steroid-induced pancreatitis. How are you going to manage this patient? So the obvious thing would be to, if you're suspecting steroid-induced pancreatitis, it's to stop the steroid, yeah? Any objections to that thought? No objections to the admitting reg stopping steroids? Oh yeah. Yeah. I think this patient has been on steroids for a month. If you get nothing out of this talk, please remember, for patients on long-term steroids, even if the steroid is causing nasty side effects like pancreatitis, please do not abruptly stop a patient's steroids, or you risk putting the patient in adrenal crisis, Addisonian crisis, which can sometimes be fatal. So please don't, even if you're suspecting steroid-induced pancreatitis, you might adjust the weaning regimen so that you're weaning the steroid a little faster, but please don't abruptly stop the patient's steroid. Cool. Yeah. So we ended up just tapering the steroid, even though I'm not actually entirely convinced that was the cause of the pancreatitis. Cool. Okay. So moving on. Complications of pancreatitis. So about 80% of patients with acute pancreatitis have mild disease, and these patients tend to recover in about 3 to 5 days without complications or any organ failure. But there's about 20% of the patients that have moderate to severe disease, and these are the patients who tend to present with local or systemic complications, or in extreme cases go into organ failure. And I've seen quite a few. I'm on a gen surge rotation at the moment, and I've seen quite a few cases of pancreatitis over the past couple of weeks. There was a case of a suspected GLP-1 agonist-induced pancreatitis that came to our hospital recently, and the patient had a few comorbidities, but actually code blued a couple of hours into her admission for quite severe type 2 respiratory failure with a pH of 7.13 and a CO2 of 110. So pancreatitis at its most severe manifestation can cause organ failure, like respiratory failure. So in terms of disease course, about 85% of patients have what we call acute interstitial edematous pancreatitis, which is characterized by enlargement of the pancreas due to inflammatory edema. But about 15% of patients have necrotizing pancreatitis with necrosis of the pancreatic tissue and also the peripancreatic tissue as well. And in terms of when we're talking about mortality, so the overall mortality of pancreatitis is quite low, it's 5%. But it's higher in necrotizing pancreatitis than it is in the more common acute interstitial edematous pancreatitis. When talking about complications, we tend to divide complications into local and systemic complications, and these are the things that we need to, pancreatitis is usually treated conservatively, so it's just supportive management. But these patients are almost invariably admitted under a gen surge unit because the complications of pancreatitis are always a surgical problem, invariably a surgical problem. And these are the things that we need to monitor for in the days to weeks following the acute presentation. And we divide complications into local and systemic. So there are 4 local complications, 2 of which develop, within a week, within 4 weeks, sorry, typically after onset of the acute pancreatitis, and 2 of which are more delayed, develop more than a month after onset of the acute pancreatitis. And both acute necrotic fluid collection and walled-off necrosis may become infected, which is then usually a trigger for antibiotic therapy. But in general, we don't tend to place patients with pancreatitis on empiric antibiotics. Now, in terms of systemic complications, so this is defined as an exacerbation of any underlying comorbidity as a result of the patient's acute pancreatitis. So for this other lady that I'm talking about, presenting with query GLP-1 agonist-induced pancreatitis, who Matt called, she probably had an underlying sort of cause for type 2 respiratory failure. She might be she was quite a large lady, so probably had some undiagnosed OSA, and then the acute pancreatitis then exacerbates that, causing quite severe type 2 respiratory failure. We would define that as a systemic complication. And then in the literature, they distinguish systemic complications from organ failure. And organ failure is usually due to this SIRS response that you get as a result of the pancreatitis. So as a result of widespread activation of cytokines. Patients can go into acute respiratory failure, shock, or renal failure, and this is what kills the patients. So yeah, we did a repeat CTAP about 7 days into the admission, just to make sure that this patient didn't develop any complications, and thankfully they didn't. So it was just acute edematous pancreatitis, which is the most common kind of pancreatitis. Although it's progressive, you'll expect it to be progressive, but the good thing is that there's no abscesses, there's no walled off, necrosis, there's no fluid collection, etc., etc. So actually, we just treated this patient conservatively. Cool. So a couple of questions there for you to think about. I won't go through them all, but hopefully, next time you think you have a patient with hypernatremia, you can sort of think through, what could be causing it in a systematic way. And I think, yeah, some sort of niche things. What blood tests would you order if you're suspicious of autoimmune? Sorry, that should say autoimmune pancreatitis. You would order a IgG4 level.
Sorry,
cool.
Victor, can I ask?
Yeah.
Sorry, I just had a question.
Yep, go ahead.
Do you mind explaining why SIADH causes hypotonic hyponatremia? I know you probably mentioned it, but I missed it.
Why it causes hypotonic hyponatremia? What would you expect otherwise?
Well, so if you're retaining water, then I thought it might be dilutional.
But I guess so. You're retaining water, but you're also so remember that SIADH is actually a euvolemic hyponatremia. So there's a dilutional component, but because of the action of ANP, you actually end up peeing out all that excess fluid. So it's actually a euvolemic state that you end up in. But the way to think about it is dilutional. So you're retaining a lot of fluid, and that would cause a hypotonic because you're diluting all the solutes in the extravascular space. I'm not sure. Would you expect differently? As in, would you expect it to be isotonic or hypertonic?
Oh no, I guess you'd expect it to be hypotonic, but maybe I'm getting confused with like a pseudo hyponatremia, like the absolute volume or the absolute concentration number of sodium molecules is the same, is in the normal range, but it's the fact that there's more water retained.
Yeah. So just to clarify, it's so SIADH is a type of hypotonic hypernatremia, and it's, if you want to specify, it's a hypotonic euvolemic hyponatremia. But yeah, you wouldn't expect hypertonicity, so increased serum osmolality, because you're diluting out all the solids, and for the same reason, you won't expect isotonicity either.
Mm-hmm. Thanks.
Yeah. Awesome. Okay, so last case, bit of a switch from so a lot of gen search is about the abdomen, and this is about the abdomen, but a bit lower down. So the third patient that we see is Mr. KL, a 42-year-old male presenting with 12 months of intermittent left lower quadrant abdominal pain. Past history, none of significance really, has had a perianal abscess drained in the past, neither here nor there, on no regular medications. From home alone, is a current smoker, quite a heavy smoker and heavy alcohol user. Here's some more information about the HOPC. So 12 months of intermittent left lower quadrant abdominal pain, increasing in frequency, severity, especially in the last 3 months. Sharp localized to the left lower quadrant, no radiation, 7 out of 10 in severity at worst, associated with nausea and rare vomits, but no hematemesis. 6 months of altered bowel habits, described as small volume, normal consistency, occasional PR bleeding, bright red in color, but the patient's passing flatus, no urinary symptoms, minimal weight loss, no loosening of clothes, but decreased appetite due to abdominal pain, and reports 6 months of drenching night sweats. Provisional diagnosis. Maybe no, bloods might. So bloods were not very remarkable. GGT was elevated, probably consistent with heavy alcohol use. CRP was not that exciting. Fibrinogen was up because it's an acute phase reactant. Any thoughts on what might be going on? Or any investigations that you would like to order if you are seeing this patient for the first time in ED as an admitting and cert patient? IBD, yeah. Could be. Why are you concerned for malignancy, Meg?
So the chronicity is concerning. The fact that he's had PR bleeding, that's always, you've got to be you have to investigate that. And the fact that he's had night sweats, anorexia, there's constitutional symptoms. It's something you want to rule out.
I would agree. And sorry, I didn't put the examination findings, but when you had a feel of his abdomen, there was a very clear palpable mass in the left lower quadrant. So actually, we were incredibly concerned for malignancy in this man, to such an extent that on admission we sent off some tumor markers. I don't remember whether he had a family history. I don't think he did have a family history of bowel cancer. But yeah, important question to ask. Yeah, so I was going straight to colonoscopy, which is actually what we did. But I want to talk firstly about these markers. Anyone familiar with these tumor markers? So what's CEA testing and what's CA 19-9? Correct. So none of these tumor markers are actually specific for bowel cancer. But sometimes there's probably, so CA19-9 is not always ordered because it's it's present, it's elevated in any sort of GI malignancy and more commonly in sort of pancreatic cancer. CEA sometimes has a role, not for diagnostic reasons, but for monitoring reasons. So often you want a pre-operative, if you've concerned for a bowel cancer, you've diagnosed bowel cancer and you want to resect that bowel cancer, usually you do a pre-op CEA, which you will suspect to be elevated, and then after the resection, you'll do a post-op CEA, and hopefully it would go down. So it has a role in monitoring purposes, but probably no role for diagnostic purposes because it's so non-specific. But anyway, so on admission, we ordered a CT chest, abdo, pelvis, and actually, so this patient presented with left lower quadrant abdominal pain. Why would we include a chest, CT chest, on the request? Yeah. So Meg, can you tell us the 4 organs that colon cancer most commonly metastasizes to?
So the lung, the liver.
Mm-hmm. Yeah.
But I'll be guessing for the rest.
So that actually, I'm going to talk about in the next slide. But yes, it's because, well, to answer my original question, we're getting a CT of the chest to look for pulmonary mets because that's one of the most common organs that colon cancer typically metastasizes to, and it's important in cancer staging. And we'll talk about that in a second. But yeah, so CT chest abdo pelvis, there wasn't really anything suspicious in the chest, but there's a large area of thickening in the sigmoid colon, consistent with sigmoid cancer, but no evidence of bowel obstruction. And I think this pairs quite well to the clinical history. I mean, the pain was in the left lower quadrant, which is where the sigmoid is. And there's no evidence of bowel obstruction, and we probably didn't anticipate there to be anything because the patient was passing colitis. But how did this? So someone said Joel said colonoscopy. We immediately did an urgent colonoscopy on this patient, and that's the best way to diagnose colon cancer. And the findings were a median-sized mass located at the sigmoid colon 30 centimeters from the anus. So during the colonoscopy, we did some tattoos, and we usually put the tattoo. So we usually take a biopsy if we can, and then if we're able to get out the entire mass, then we put some tattoos to remember where we took the mass out or where we took the biopsy from. The diagnosis was primary malignant tumor in the sigmoid, 30 centimeters from the anus. So this was done as an inpatient. The patient was returned to the ward, and then the next day, so this was done in the afternoon, we fasted the patient from midnight for a laparoscopic anterior so more specifically a sigmoid colectomy. And we performed the sigmoid colectomy, and the histology came back as sigmoid adenocarcinoma. And just to be clear, sigmoid colectomy involves taking out the disease part of the sigmoid colon, including the associated mesentery, and then basically you ligate the inferior mesenteric vessels that supply that region of the colon close to its margin. And then what we do, it depends on the situation. If there's complications like abscesses, or if the bowel is incredibly inflamed, then sometimes we might do a temporary colostomy to give the bowel some rest, and then reverse the colostomy, weeks down the track. But in this patient, there weren't any sort of real complications, so we actually connected that part of the descending colon directly to the rectum without a need for any colostomy formation. So in terms of diagnosing colorectal cancer, so colorectal cancer can present in 3 main ways. So in this patient had some suspicious symptoms and signs, and that's one way that colorectal cancer can present. Often it's asymptomatic, so often you'll see asymptomatic patients being teed up for an outpatient colonoscopy because on the back of a positive IFOBT test, which they did as part of the National Colorectal Cancer Screening Program. So that sort of is a large proportion of cases of colorectal cancer diagnosed. They present asymptomatically. And then in a very small proportion of patients, they present with an emergency, intestinal obstruction, perforation, rarely an acute GI bleed that doesn't self-resolve. And to go back to the question that I asked Meg earlier, so where are the 4 sites of metastasis for colorectal cancer? So regional lymph nodes is probably a giveaway, but liver, lungs, and also peritoneum as well. And the best way to diagnose colorectal cancer is using a colonoscopy. In terms of clinical staging, so you need to think about clinical staging prior to surgery to really plan how you're going to manage the patient's colorectal cancer. And it usually consists of sort of 3 main things. So the easiest thing to do is tumor markers. And as I said, it's not for diagnostic purposes, but it's for monitoring purposes. So CEA is the most commonly used tumor marker. It's been shown that people with an elevated CEA have worse prognosis. Those with colorectal cancer with an elevated CEA have worse prognosis. And if these patients get bowel resection and then you repeat the CEA postoperatively and it doesn't fall or it doesn't normalize, then that tends to imply the presence of persistent disease. So CEA is important for monitoring. There are some other markers that are sometimes used. One is CA19-9, and I think someone mentioned that this is usually related to cancer of the pancreas, but can be present in any GI malignancy. And there's another one called CA125, which you may or may not have seen ordered on the ward. Does anyone know what CA125 is a marker for? Yeah, great. Ovarian cancer. So it's a marker for any serous carcinoma, but most commonly, the most common serous carcinoma is carcinoma of the ovaries. But again, very non-specific. The other thing is that you need to glean the family. So the other thing is a CT chest abdo-pelvis. So chest abdo-pelvis pretty much covers the 4 main sites of metastases, and that's important for clinical staging. And the third component is to establish a family history, because and preferably going at least 3 generations back. As the patient can be, as you know, there are some disorders, inherited disorders that predispose patients to colorectal cancer, and it's important to determine whether the patient is a member of a family with that predisposition. So a bit about the genetics of colorectal cancer. I won't talk too much, but two main types of familial CRC. So most colorectal cancers are sporadic, but there are some inherited types of CRC as well, usually associated with the familial colorectal cancer syndrome. The more common one is Lynch syndrome, also called hereditary non-polyposis colorectal cancer. And does anyone remember what the genetic abnormality is in Lynch syndrome? So I guess I have the answer here, mutations in the MMR genes. What are the MMR genes? Do people remember? Yep, so mismatch repair, but there are 4 DNA mismatch repair genes. What are they? I'm probably asking you to really stretch your memory back to preclinical medicine. So there are 4, and this is important because now all colorectal cancer specimens are sent for immunohistochemistry or for genetic testing, just to determine whether the colorectal cancer is sporadic or inherited. And yes, as Alex posted there, it's MLH1, sorry, MHH2 and 6, and PMS2. And this results in what we call microsatellite instability. And CRCs that develop from Lynch syndrome are characterized by an early age of onset, and it's predominantly a right-sided lesion. So this patient has a left-sided sigmoid lesion, but predominantly Lynch syndrome cancers are right-sided. And the mean age of diagnosis is probably around in the mid-40s, so 48 is the oft-quoted mean age of initial colorectal cancer diagnosis in Lynch syndrome patients. And there are also, so Lynch syndrome is also associated with increased risk of other types of cancer. And there's one cancer in particular that patients are at increased risk for. Do you guys know which type, apart from colorectal cancer? Nope, not breast. Yes, ovarian, but yeah, mainly endometrial. But yeah, so it's really Lynch syndrome. When you think of Lynch syndrome, think of 2 things: colorectal cancer and endometrial cancer. But certainly it can put you at increased risk of other malignancies as well, including cancers of the ovary, stomach, genitourinary system, etc., etc. But think 2 things: endometrial cancer and colorectal cancer. FAP is incredibly rare. Less than 1% of colorectal cancers are caused by FAP. And as I have put down on the table, usually caused by germline mutations in the APC gene. And typically in FAP, you see, it's pretty obvious when a patient has FAP. Not sure if you guys have seen any colonoscopy images of FAP, but it's they have multiple polyps developing, even as early as childhood. And colorectal cancer occurs in 90% of untreated individuals who don't undergo prophylactic colectomy by age 45. So why is this clinically relevant? So I've put the 4 MMR proteins there. It's because, as I said, we routinely test all CRCs. When we resect them, we test them to see whether they're likely to be sporadic or inherited. And obviously, if they're sporadic, then you don't need to test family members. But if it's inherited, then there are implications for genetic testing on other family members as well. And there are several tests that we perform. So we can perform immunohistochemistry staining for the expression of the 4 MMR proteins. And if all the MMR proteins are expressed, then chances are it's sporadic, that it's not Lynch syndrome. In Lynch syndrome, we expect none of these proteins to be expressed. Now, sometimes the immunohistochemistry is a bit equivocal, in which case we can do what we call microsatellite instability testing, or MSI testing, which is a PCR test. And that divides tumors into MSI high and MSI stable. And MSI high means that it's a greater risk of being inherited or related to Lynch syndrome. The next thing that we test is germline MMR gene panel testing, and we test for mutations in the genes rather than the protein expression levels. And if they're positive, if the gene panel test is positive, then chances are the colorectal cancer is due to Lynch syndrome. Sometimes, the immunohistochemistry can be a bit confusing. So sometimes they reveal absence of MLH1 and or PMS2 protein expression, which can sometimes be sporadic or sometimes be inherited. So often, in order to classify whether the CRC is more likely to be sporadic or inherited, we follow up with BRAF testing. So and MLH1 promoter methylation testing. And these two, I guess you don't need to know the specifics, but these two things are associated with sporadic CRCs. So if you get an equivocal sort of immunohistochemistry result, sometimes we do BRAF V600E mutation testing and MLH1 promoter methylation testing. And if they're present, then chances are the colorectal cancer is sporadic, and we don't need to worry about the familial genetic testing of family members. The genetics are also important because it determines the surgical approach that's taken, because in familial cancer, often we lean towards total colectomy sometimes rather than subtotal colectomy. But anyway, we're out of time. I'll let you guys have a look at these questions in your own time, potentially when the recording gets uploaded. But the next virtual ward round, unfortunately for unforeseen reasons, this ward round had to be pushed back by a week. So the next ward round is going to be coming up in next week, next Thursday, same time, same place, and it's going to be on hematology. Yeah, thanks everyone for joining in, and hope you have a good rest of the evening.